Respected Chairperson, London audience, ladies and gentlemen, good morning, and Assalamu alaikum. I think most of us are now feeling sleepy, but I'm just trying to draw your attention to have my presentation today. I'm highly honored and privileged to be here in presence of this August gathering. So I'm going to present graft angioplasty, all we need to know. We all know that the ischemic heart disease is the leading cause of death throughout the world. And the 64 million people are suffering from this. So we can only see the top of the iceberg. What is at the bottom of the iceberg, we don't know. So it reflects the gravity and the disease burden. The coronary angiogram is the setting of CABG, is important diagnostic tool for evaluation of native vessel and the bypass graft patency. Coronary intervention is disease graft and the native vessels are common practice for the treatment of the patient presenting with ischemia and angina. Despite of having major advances in catheter-based therapy, adjunctive pharmacology therapy, coronary bypass grafts, intervention remains critical challenge for the interventional cardiologist. Coronary bypass intervention is related to a high radiation exposure, prolonged procedural time, large contrast use, and also the risk of complication to the patient. PCI is the preferred treatment strategy for the revascularization in CABG patient due to the higher surgical risks. Now the bypass coronary intervention, we all know that is indicated for a highly symptomatic patient when with recurrent ischemia or in the event of post-operative instability or with abnormal biomarkers, ECG suggestive of perioperative MI factors that favor reduced surgery. Let's have a look for that. Multiple vessel involvement, severe vein graft disease, poor LV function, total occlusion of native coronary arteries, and the availability of the arterial conduits. Now, what is our background of this study and the presentation? CABG is major therapy for coronary artery disease. The myocardial ischemia syndrome that occur 3 to 5% of the patient immediately after CABG, and the recurrent ischemic symptom appear in 4 to 8% of post-CABG patient annually. In a majority patient, the culprit vessel has been found to be a vein graft and the considerable lesion-associated thrombus and often progression to coronary artery disease. There is a significant angiographic defects, up to 12% of the graft observed immediately after CABG. So the 10-year patency rate of internal mammary artery graft is in around 85%, and the 10-year patency rate of saphenous vein graft is only 61%, and 10 to 20% of the patient require revascularization within 10 years after CABG. So the study revealed that the coronary artery bypass graft patency rates, in case of saphenous vein graft, it is 81 to 97% within 1 to 5 years, and the late patency remain 50 to 60%. So these are the internal mammary artery, radial artery, and the saphenous vein graft. Now the selection of the guide of the catheter. So it's a different artery setup. So in case of optimal guide catheter selection for the primary or the multipurpose, it may be Amplas or Judkins, and the graft has more anterior takeoff, then it will be the Judkins and the Judkins bypass multipurpose. General bypass graft versus, so this is the graft, ostium and the body, distal anastomosis, native artery, the straight left anterior oblique view in case of Lima 2 LED, and the distal anastomosis to look after by that left anterior oblique view, and the epicanial for the native artery. So you can see that these are the venous graft, native vessel, and the Lima 2 LED. And there is the last of the Lima 2 LED, venous graft, and also that. So the graft angiograft left radial artery now is the subject of discussion everywhere in the world. The left main coronary artery, left anterior oblique view, caudal view, and the right coronary artery, left anterior oblique view. And for the saphenous vein graft, to the posterior and the descending artery, that is the right anterior oblique view. It is easily visible. And grab vessel anastomosis, the tunnel where code for recording number and the origin of the coronary artery bypass graft. So by seeing that, we can understand what will be the tunnel wire code and what will be the anastomosis and its interpretation. Recommendation for revascularization. What is that recommendation? Percutaneous coronary artery intervention, that is the native vessel or grab vessel, or twist and strategy, regulating bare metal or reduce CABG. The guideline says that in patient with previous CABG with patent Lima to LAD who need to repeat revascularization, if PCI is feasible, it is reasonable choice of PCI over CABG. In patient with previous CABG with refractory angina, guideline-mediated therapy that is attributable to Lippmann disease, it is responsible to choose the CABG over PCI1 and internal memory artery can be used as a conduit to the left LAD. Now, the saphenous vein remain most commonly used the graft, including CABG. And saphenous vein lesions are frequently associated with the considerable plaque burden and intercoronary thrombus, which increases the risk of peri-interventional adverse event like distal embolization, bleeding, no reflow, graft perforation. And besides that, despite of having advanced surgical technique and the pharmacotherapy, saphenous vein graft failure rates and the restenosis remain high and often requiring subsequent intervention and poor long-term outcome. So you can see what is the natural history of saphenous vein graft failure. First of all, there will be the early remodeling, occlusion within 0 to 1 year, intermediate lesion 1 to 5 years, severe lesion, and more than 5 years, there will be total occlusion. Higher rate of failure, why there is rate is so high in case of saphenous vein graft? Because there is the intimal thickening, gradually it leads to the bulb fibrosis and aneurysmal dilatation, anastomosing intimal hyperplasia. So later on, it switch on to the complete occlusion. The causes of perforation is rare, but the greatly feared complication are vessel wall penetration with guide wire, inflation of the balloon is a subintimal location, overexpansion of coronary artery or graft ablative technique, and the stent implantation. The treatment, prolonged balloon inflation, reversal of the anticoagulation are effective in stabilizing the most patient, and covered stent is a hope for us, and size of the balloon and the stent of the normal adjacent vessel are slightly smaller. What we are going to do when there is thrombus burden? So we can do the mechanical thrombectomy, aspiration thrombectomy, and laser thrombectomy. And these are the intercoronary microvascular vasodilator we can use, that is the adenosine nitroprusside. We all know that. And it is more effective to administer the drug using the microcatheter and infusion catheter over the time where the balloon placed distally. And the severe stenosis and the distal occlusion, we can manipulate like this. And internal memory artery, the PCI in the internal memory graft lesion, 97% postural success, and the TLR of 7% at 1 year. So you can see there is a Lima to LAD severe stenosis before stenting. We did in our setup, and after that, stent deployment. That is the final result. Now, the treatment of the saphenous vein graft disease, what we can do. I have already mentioned that in select patient, the previous CABG undergoing PCI of saphenous vein graft, the use of embolic protection device, when technically feasible and reasonable to decrease the risk of distal embolization. And the patient with chronic occlusion of the saphenous vein graft, percutaneous devascularization of the venous graft should not be performed. So you can see the saphenous vein graft stenosis before and after implantation of the stent, and this is the final result in our setup. And this is the native vessel, PCI. We did the Lippmann to LCX, so this is the final result. So nowadays the subject of discussion everywhere, what will be our interventional procedure in CTU case. So they said that the higher technical and procedural success is if we approach through the saphenous vein gap. The higher contrast used, increasing risks of contrast, we all know that. So these are all we can overcome by our technical expertise. Higher risks of the venous graft rupture and old degenerative vein grafts, higher risks of restenosis after balloon angioplasty and the stenting. So general consideration, keep the activated clotting time to be higher rate and consider thrombectomy in relation with a heavy thrombus burden. Now in the conclusion, a graft angiography of the coronary artery and bypass graft provide information about the graft patency. Due to a significantly higher risk of reduced CABG, PCI is preferred method of treating patient with diseased graft and the native vessel. Saphenous vein graft intervention can prevent unique challenges for the interventional cardiologist. It is important to apply the strategies to minimize complication and optimize outcome of graft or native vessel PCI. The patient presenting with acute coronary syndrome often needed coronary intervention and carries increased risks. PCI of native vessel arteries is generally preferred over saphenous vein graft intervention. Embolic protection device reduces the risk of distal embolization during saphenous vein graft PCI. DS is the preferred choice of the stand in native vessel, and while DS or BMS could be used for the saphenous vein graft PCI, post-CABG revascularization strategy should be based on the assessment of the discussion of a heart team approach. So thank you very much from the team cardiology Combined Military Hospital. Thank you very much for patient hearing.